Liviu Klein and Mike Gibson coming to you live from AHA 2024, and we're talking about a new AI technique called the SEISMocardiogram, cool new name, using true AI to assess intracardiac filling in patients with heart failure, talking about the SEISMIC Heart Failure 1 study. Talk to us a little bit about this new technique.
Yes, thank you for having me here. We're using a very interesting phenomenon that it's known probably for over 100 years, which is the heart motions in the chest and the kinetic energy that the heart imparts to the aorta has been actually captured for a long time. If you think about the weighing scales that we have where the needle moves before it gives you the weight, that's exactly that motion. So we're able to capture that motion with triaxial gyrometers, accelerometers, essentially in the 3 dimensions, and using that, and also using PPGs and ECGs, we're able to capture this heart motion. And it turns out that the heart contraction and relaxation, it's tied to intracardiac filling pressures. So whatever the heart is doing, it's in relation to the Frank Starling curve. So we're able now with this technology to look at intracardiac filling pressures, to look at peak oxygen consumption. We really hope to change the way we see hemodynamics non-invasively.
And what was the truth standard that you compared these measurements to?
So we compare that to the right heart catheterization done in the cath lab. So the true gold standard, patients had the SEISMocardiogram on them at the time of the catheterization, and we performed the routine right heart cath. Some patients had vasodilators administered, inotropes, or exercise. So we took whatever was the standard of care.
And for the left-sided pressures, what did you use? The wedge pressure, or what was used there?
Correct. So the first study that we did, the SEISMIC-HF1, it looks at the wedge pressure as the best estimate for left-sided filling pressures. We have data that we hope in the future to develop for PA pressure, right atrial pressure, but for now, we present the data for the wedge pressure.
And what did you find?
So we find a great correlation compared to the gold standard. We had our sample, we had about 940 patients enrolled, about 320 had reduced ejection fraction. So we focused our work on HFrEF. And in that population, our algorithm can detect the wedge pressure essentially with a R-squared of 0.74 and a mean difference of about 1 millimeter of mercury. If you look at the blind Alman analysis, so the two standard deviations, plus 11 to minus 10 millimeters of mercury. By comparison, the things that we use currently in clinical practice, such as CardioMEMS or Cordella, the implantable PA pressure sensors, have the same error. So we really are able to determine non-invasively same hemodynamics that a implantable hemodynamic sensor does.
When you say 1 millimeter difference, that's either plus or negative. That's an absolute difference between the numbers?
Correct. So the standard, the mean difference was one plus minus 5 millimeters.
Great. So what's the regulatory pathway for something like this? How do you get something like this approved, and what data do you need, and how far are you along?
So we have been talking to the FDA, and we got a breakthrough designation last year. We're in discussion to look at this data that we are presenting today at the AHA. And then possibly a follow-up study to once the algorithm is locked in other centers that have not been part of this first study to confirm the algorithm. And we hope that we get FDA clearance for that next year.
Amazing. This always never ceases to amaze me, all the progress. Well, congratulations. Great work. Thanks for sharing with us, and thanks for all of you for joining us here live from AHA 2024.